welcome back, everyone. The task I have to do for this afternoon is highlight really the value of risk stratification of patients with thyroid carcinoma. For this, I'll set my objectives. The first one is to explore the place of the current guidelines. Second, highlight the importance of risk stratification, delineate the limitation of most of the university available staging system, explain the application of dynamic staging, and demonstrate and conclude with a practical clinical case. And since we're becoming smaller and smaller groups, I'll try to make it interactive, if that's okay with you. Now, where are we as far as our current guidelines? Our current guidelines evidence-based medicine? Well, effectively, if we look at our own region, really, which really is of interest to us, when we talk about evidence-based medicine, there are 4 elements that really are necessary to fulfill the criteria for EBR. One is that there should be questions relevant to clinical practice. This question, if really is not answered, to answer this question, you have to go to the literature or clinical trials and to see if really there is any good studies that really of highly rated, that randomized studies or really of high quality that you can use to make some idea about the question that you're asking. 3, there should be some, the physician that usually are expert or in their field that get back to you with some answer. But more important than anything, it's the patient's feedback, that really the patient is at the center of every decision as far as really evidence-based medicine. So what do we have here? Do we have guidelines in the region? None so far. Do we have really any, if we don't have guidelines, do we have really clinical trials that really are based on strongly randomized studies, even in the North American countries, European countries. Until recently, there have been some randomized trials. Most of the previous studies were retrospective studies. So we're lacking 2 of the most elements really in the evidence-based medicine so far. And in fact, this is not a problem that's really unique to our region. Is in fact, most of the studies have been based on risk stratification based on staging systems that have been put to help really give some idea about the prognosis that really will follow treatment of the patient with surgery and in some cases with radioactive iodine treatment. But again, when we talk about risk stratification, and I have to say that really you're going to be seeing some of the slides that were given courtesy of Dr. Tuttle from Memorial Sloan Kettering Hospital, not really that I have a good relationship also with MD Anderson, which are really well represented here today. There are really different stages and categories in disease risk stratification. The one related to disease-specific mortality, the other one related to risk of recurrent and persistent disease. The third one is the risk of additional therapies. For instance, if we consider that patient is a low risk with microscopic papillary carcinoma, adding radioactive iodine therapy, is that harmful or non-harmful? And the last one is risk of observation. When we observing a patient with microscopic and low risk patient without really any additional therapy than surgery, or even with limited surgery, are we limiting or enhancing the risk that really attributed to the patient? Having this, I looked really to see how many staging systems are available, and you do a search in the internet. There are close to around 17 available staging systems that are present on the market. And then actually there have been some rating systems, and there are 3 that really highly rated: the TNM AJCC, the MACES from Mayo Clinic, and the EORTC from the European staging system. However, for most of the staging system, they all predict risk of death in differentiated thyroid carcinoma, and based on element really essential in their staging relating to age, histology, tumor size, completeness of resection, metastases, but none except for one that really look at the risk of recurrence or the impact of initial therapy on the persistent or recurrent disease. And if, in fact, if this is really a study that really was run by Tuttle and his group at Sloan Memorial, where they looked at a cohort of 588 patients that were subjected to total thyroidectomy and radioactive iodine treatment for differentiated thyroid carcinoma. And they looked to see whether what would be the impact of applying the staging system on the risk of persistent and recurrent or death in their patient. And they followed the patient for a median follow-up of 7 years. And interestingly, if you look at the here you look at the different stages in that staging system. This is being the lowest going to higher, and the highest being the stage 4. In blue is the risk death. In red is the risk of persistent or recurrent disease, and then in green is no clinical evidence of disease. And if you look among all stages, okay, there is no pattern, really. You look like you might have the same risk of persistent recurrent disease in stage 1 or in stage 4. Whereas where there's consistency is really when you look at the risk of death. You see that the lower staging have lower risk of death compared to the one really at stage 4, which have close to 18% risk of death. So this staging available now and using the university acceptable one, the AJCC, seem to predict only death, not really the risk of persistent or recurrent disease. And this has been effectively well recognized by the American Thyroid Association, which came up with their updated recommendation in 2009, and they highlighted that really there is a need to individualize patient assessment and risk, and then actually some of the 15 out of 100 recommendations were based on individualized risk of death and risk of recurrence. Now, the other one that really, staging system that really might be relevant to our region here is the one adopted by Ankara Oncology Training and Research Hospital in Turkey, where they included a pre-treatment element as well as post-treatment element, post-treatment being the adequacy of the type of surgery, whether it's complete or subtotal thyroidectomy, or whether the patient received radioactivity or did not receive radioactivity. So on that basis, the American Thyroid Association Surgical Affairs Committee met and then established some comprehensive list of elements for post-operative follow-up for risk management and stratification that they felt are essential for any risk stratification model that anyone has to come up with. And those are based on pre-operative, intraoperative, and post-operative elements. It's obvious in the pre-operative phase that physical examination take precedence, followed by some historical features like in some advanced cases unexplained bone pain, suspicious of distant metastases, imaging findings that really are found by ultrasound, chest X-ray, CT, MRI, scintigraphy, PET scanning, and lab findings that might affect really the amount of radioactivity that you might have to give to your patient, whether the presence of leukopenia or advanced renal disease. In the intra-op, they look at clinical findings such as the extent of thyroid disease, whether it's complete or non-complete, the description of gross extrathyroidal extension being a hallmark of really aggressive disease, completeness of resection, incomplete being really a risk for further recurrence and persistent disease, and resection and damage to major structures. And also there's some element in the post-operative phase, which really I'll address at the later. But again, at this stage, most of the staging system addressed only the two first elements I mentioned about, the pre and intraoperative elements. On that basis, the ATA and American Thyroid Association recognize that probably based on the findings and those elements that really I mentioned about, the three elements pre, during, and after surgery, that one should be able to stratify those patients into three categories that labeled as low risk, intermediate risk, and high risk. And each category carries with it a certain percentage of persistent or recurrent structural disease. The low risk, in the low risk group, they consider patients with classical papillary thyroid carcinoma with no evidence of local or distant metastases, where there has been complete resection of the tumor and the thyroid. No tumor invasion was found during surgery. There was no vascular invasion on testing the pathological specimen, and if given, no radioactive iodine uptake was found outside the thyroid bed. So in this group, they carry overall a risk of 1 to 5% of persistent in the upcoming 5 to 7 years of having persistent or recurrent disease. In the intermediate group, those who have a little bit more advanced finding, either they have some cervical lymph nodes were identified at the time of the surgery or before. There is macroscopic evidence of extrathyroidal extension, and the definition of that was well explained by Dr. Nabil. It's basic involvement of the fat, muscle cells really around the capsule around the thyroid. And aggressive histology, whether it's of the tall cell type, insular type, all those that really are known to have and to carry on aggressive behavior. And most importantly, vascular invasion. Now, in this group carries a risk of 5 to 30% of really having persistent or recurrent disease in the upcoming years. Finally, the high-risk group is the one having evidence of microscopic gross extrathyroidal extension, incomplete tumor resection, evidence of distant metastases, and inappropriate thyroglobulin elevation, which really persistent and progressive, and those who have more than 30% risk of progression and persistent disease. So on that basis, again, the same group that, and this is a slide provided by Dr. Tuttle, that they looked at really how would they apply that system that really was adopted by the American Thyroid Association. Can they predict the persistent recurrent disease or death in those subcategory of low, intermediate, and high risk group? And then they joined the results with another study that was done not in USA, but was done in Rio de Janeiro in Brazil. And actually, the results really were quite comparable, which indicate that that system of classification into low, intermediate, and high might have some value actually in predicting the progression of disease. If you look in the low-risk group, actually they found that there is a 14% risk compared to 13% risk in the Brazilian study. In the intermediate group, that risk increase of 44% compared to 37%, and then it's high at 86% persistent to recurrent disease compared to 85%. And this is following a cohort of 1,194 patients for a median follow-up of 7 to 10 years. Okay, so there is value in really at the time really when surgery and it's being performed really is to look at the data and to classify your patient whether they are low, intermediate, or advanced as far as high risk group for recurrence. Having said this, it's really relevant to note also that really the prediction is really also important because in the low risk and intermediate group, most of the recurrence actually is in the form of biochemical recurrence, not in the form of structural recurrence. Whereas if you look at the high-risk group, okay, most of the recurrence actually, or the persistent disease, is in the form of structural disease, which is represented in red, blue being biochemical recurrence or persistent disease. Now, one is take into consideration that now it's quite relevant that really we got to the stage where we can put patient into high, low, high, intermediate, and high based on the clinical pathological data, but it's also good to see what would be the effect of treatment imposed on certain patients. Patients who have been classified at high risk, if they do respond very well to surgery and radioactive iodine treatment, their risk should not remain the same risk as really initially put in the picture. And the same if someone who has been labeled as low-risk patient might later on respond with further aggressive disease and progression, and labeling that patient as all along as low risk will also be inappropriate. So there should be some dynamic way of following really not only the initial phase, but look at the response to therapy and then reclassify your patient all along. That will make more sense. And on that basis, there had been some attempt also to categorize patients not only based on the initial clinical pathological findings, but also on the type of response. And an excellent response is considered as anyone having suppressed and stimulated thyroid globulin less than 1 nanogram per ml, neck ultrasonography without evidence of disease, cross-sectional or nuclear medicine imaging negative if really is performed. An acceptable response is any of the following, basically a little bit more advanced stage: suppressed thyroid globulin less than 1 nanogram, but stimulated thyroid globulin between 1 and 10 nanogram. And neck ultrasound, non-specific changes, and some maybe sub-centimeter lymph nodes, and then cross-sectional or nuclear medicine imaging, non-specific changes, although not completely normal. So basically, it's a basic acceptable response is more like of a biochemical evidence of really persistent disease with some non-specific changes in the neck. As a matter of fact, any clinical response is considered really that has some evidence, clinical N1, what we call disease, is anyone that has 10 lymph nodes, okay, that really are less than 5 millimeter, or someone who has 5 lymph nodes between 5 and 5 millimeter to 10 millimeter, or someone who has 1 lymph node but higher than 1.5 millimeter are considered to have significant clinical disease. So some few lymph nodes that are less than 5 millimeter are really non-significant and could be followed and observed with no any further attention. Now, if we look at the risk stratification, people who were classified, even classified as high, low, or intermediate, but have excellent response to treatment, the risk of having now changes from to a lower risk and having a risk of recurrent persistent disease in the 4% if they have excellent response, whereas it moves to 13% if they have acceptable response, and then to 96% again if they have really poor response. And it's for relevance again that in the excellent and acceptable response, really most of those who have some evidence of persistent disease is in the form of biochemical markers rather than true structural disease. So the concept seems changing, and then on that basis really one should really address the issue of and follow their patient on that perspective. And on that basis, let me start give you a case, and that's where I'll ask your interaction, just because it's getting to be late and everyone had heavy lunch. So let's start with this patient. A 35-year-old female in whom asymptomatic palpable thyroid nodule was detected incidentally. So 35-year incidental finding. Ultrasound, 3 centimeter thyroid nodule in the right lobe, and several abnormal right cervical lymph nodes at level 3 and 4. Okay? Final aspiration confirmed well-differentiated thyroid cancer in the nodule and a representative lymph node. Okay? So on that basis, how do we do you want us to classify this patient? Let's put it as far as the AJCC staging system. How do you consider that patient? Is it stage 1, 2, 3, 4? Any quick, I give you just one few seconds. 1 or 2? Okay. Well, if you look at the TNM classification, anyone, actually they have two, like subdivided really based on age. Anyone below the age of 45 has only 2 stages, irrespective of the presence of the tumor, the size of the tumor, lymph node, and stage 2 if they have additional metastases. Stage above age 45, okay, then they have subdivision between T1, T2, T3, T4. So this patient was 35, so it's less than 45, with no evidence of metastasis, distant metastases, so she would be considered as stage 1, right? Okay, so she underwent total thyroidectomy, central neck dissection, and compartment-oriented right neck dissection. The operative node described complete resection of tumor and lymph nodes with no gross extrathyroidal extension. Final pathology, 2.5 centimeter classic papillary thyroid carcinoma with minor extrathyroidal extension into perithyroidal fat. 14 out of 24 lymph nodes also contain well-differentiated papillary thyroid cancer. Now, you had the first staging. You did stage the patient based on the initial finding. Then you had surgery now, and you had the pathology. So we can use the ATA type classification. Would you consider this patient as low, intermediate, or high risk for a recurrence? Intermediate? Okay, let's see. Well, actually that's right. It's basically is intermediate, because if you look under intermediate, as I mentioned to you, is someone who has microscopic invasion of tumor in the perithyroidal soft tissue, and that's what the patient had. Cervical lymph node, okay, that's what she had, okay. So basically, it's a patient now, based on the finding that we have, has intermediate risk of recurrence, and that risk is in the range of, that goes probably in the range of 18 to 21% of having recurrent disease within the upcoming 5 to 10 years. Very good. Now, 6 weeks post-operatively, she received 100 millicuries of radioactive iodine-131, and the post-therapy showed uptake in the thyroid bed and perhaps minimal uptake in what we presumed to be right neck lymph nodes with no structural correlate. Her stimulated thyroglobulin at the time of ablation was 14 nanogram per ml, with negative antithyroid antibodies. Okay, so it's a true elevation in thyroglobulin. Okay, she is followed with suppressive thyroglobulin every 6 months for 2 years. Neck ultrasonography once a year for 2 years, and also has stimulated thyroglobulin done at 18 months after ablation. Okay, so that's the scenario 1. Okay, so her suppressed, after really 2 years of follow-up, her suppressed thyroglobulin is now less than 1 nanogram per ml, with negative antibodies at 6 months. Simulated thyroglobulin is also undetectable at 18 months of follow-up, and neck ultrasounds completely normal at 1 to 2 years of follow-up. So how would you label this response? Is it excellent, acceptable, or poor response? It's an excellent response, really. That's really basically all definition, really classifying those patients based on the tabulation I gave you. So that's good. That could have been different, okay? The patient could have had serum thyroglobulin rose from 6 nanogram at 6 months to 14 nanogram at 12 months, 36 nanogram at 18 months, and 77 nanogram at 24 months of follow-up. Neck ultrasound did not reveal new disease, but an MRI of the neck revealed 2 centimeter high retropharyngeal lymph node that was FDG avid on PET scanning. Would that be poor prognosis or bad prognosis, having a avid FDG on PET scanning? Probably poor. I mean, that's really, you have to teach me that, not me, not me telling you this. Chest computed tomography revealed sub-centimeter pulmonary nodule at 6 months that increased to 1 to 2 centimeter in size over the first year of follow-up and changed from FDG PET negative to PET positive. Post-therapy scanning following an additional therapy of 150 millicuries was negative. So based on this, obviously this patient has now be classified an incomplete response to therapy, and her prognosis of having a recurrent and persistent disease, or even that goes really very high in the 80 to 90% of the upcoming few years. So this is really how really that what really would it's basically I wanted just to highlight really the concept on how things really have evolved from really how initial staging to a little bit looking at really the clinical pathological findings, to looking at really the response of treatment that the patient would have, to look at the evidence of, or the prediction of really whether you can predict really disease progression or not. But again, in the upcoming ATA guidelines, and I was given the permission to provide you with this, this will be appearing in June 2014, quite in the upcoming few months, that they feel really that also should be modified and to include really some other elements that they feel should be a little bit more extensive. So really just rather than simplifying things, really just complicate things. And then each they include now molecular markers, BRAF mutation or present or non-present, whether you have a wild type of BRAF mutation or mutant BRAF mutation, whether you have really extension in the perithyroidal space or not. And each group of those will be considered as low risk in the one below and going up as the one in that red square, or in the intermediate if really there's evidence of more extensive disease by vascular invasion or not, or in the high risk group, and each one carrying really a risk of recurrence I mentioned to you in the low risk 1 to 5%, and the intermediate group 5 to 30%, and the high risk group more than 30%. So with this, I just summarize really my presentation. Basically, I tried to highlight that the risk stratification allows accurate disease staging and prognostication. This process permits the identification of the low risk, intermediate risk, and high risk category, but the response to treatment is an essential element to consider in the dynamic risk assessment process.